The anus. The anus.
We will also discuss the different accessory organs that assist us in digestion. So we'll cover the salivary glands. We'll talk a little bit about the pancreas, the liver, and also the gallbladder. The whole purpose of the digestive system, number one, is to intake food for digestion and the absorption of the appropriate nutrients. And then at the end will be the elimination of any waste products. So the alimentary canal includes the oral cavity, the pharynx. It's just broken up into three different sections. You have your nasopharynx, oropharynx, and your laryngopharynx. Next to where your canal is going to be the esophagus. It's an extension of the laryngopharynx. From the esophagus, you have the stomach and then the small intestine. So in our discussion today, we will only be talking up to the stomach. The small intestine, proximal small intestine, which is the duodenum, we will cover in this chapter. The remaining extension of the alimentary canal from the jejunum all the way down to the distal large intestine, we will talk about that in our next discussion, okay?
Mm-hmm.
All right, so accessory organs, you have your salivary glands, along with mastication, dissolves food to aid in digestion. Digestion is broken up into two basic categories. One of them is mechanical digestion, which involves teeth, the tongue, and then the chemical part of digestion where you have the different fluids that have enzymes, bile, insulin, all those different things are the chemical part of digestion. So going back to the salivary glands, saliva aids in the breaking down of the food. So what did we say mastication was?
Chewing.
Chewing, okay. What's another word for swallowing?
Good question.
You guys remember that? So we know mastication is chewing. Swallowing is what? Deglutition. You guys remember that?
No, I do not.
No.
Say it again.
Did I just make that up?
Deglutition.
I think you did.
Deglutition.
Can you spell that?
I can't.
Can you use that in a sentence?
I'm going to deglutinize this, I don't know, Snicker bar?
That sounds good.
Yeah.
So what's the word again?
Deglutition. I think it's on a couple slides now, so we'll evaluate that later. Okay, so your salivary glands, you have three glands. You have the parotid, the submaxillary, and sublingual. They're named by the location of the glands. We'll cover that in greater detail again in a couple of slides. Your other accessory organs are your pancreas, your liver, and your gallbladder. What is the purpose of the pancreas? Is it pancreas? Pancreas.
Pancreas.
Pancreas. So it's 3 syllables?
Yes.
Okay. What's its function?
Enzyme.
Insulin.
And insulin.
Okay, so what's the whole purpose of insulin? What is it?
Blood sugar.
Blood sugar. Okay, so your pancreas regulates your blood sugar. What about the liver?
Bile.
Bile. What's bile?
Breaks down fats.
Okay, emulsifies. Yeah, breaks down fat for easier digestion. Okay, and the gallbladder
Stores the bile.
stores bile. All right. So salivary glands, your saliva is composed 95.5% of water. 0.5 of that are composed of solutes, salts, and digestive enzymes. So again, as we mentioned in the previous slide, you had 3 salivary glands based on the location. So what were the names? We have parotid,
Submandibular.
sublingual, and submaxillary, right? Sublingual, parotid, submaxillary, and sublingual. So what's this? Parotid,
Sublingual.
sublingual,
Submaxillary.
submaxillary. Okay. Oh, there it is. All right, the liver and the gallbladder. Are we familiar with the liver? I mean, as far as its location, do we see this in other types of radiographs other than a KUB or abdomen? Where else can you see it?
Chest?
Usually in the chest section, right? Because when you see the liver, that's kind of the very top of the liver is the separation between your chest and your abdominal cavity, right? Separated by the diaphragm. Right underneath the diaphragm is your liver, located at the, which quadrant is this?
Right upper.
Right upper quadrant. Are you guys using that? Have you heard some of the texts use those terms yet? Quadrants, right upper quadrant? Okay. So the liver is located in the right upper quadrant. When you're looking at the liver from front to back, the most anterior, you're not going to see the gallbladder because the gallbladder is going to be located on the back side of the liver. Okay, so you're not going to see that. The liver can be broken down into 4 different lobes or 4 different sections, and they can be broken down into major sections, so major and minor categories. The major lobes is the right and the left. And again, this is the anterior view of it. So these are your major lobes, the right and the left. Separating the right and the left is the falciform ligament. It's what separates the two. And then when you look at the back side of it, you have your minor lobes. On the upper part, the upper portion is your caudate lobe. And then down here is your quadrant lobe. The quadrant lobe is separated by the gallbladder and the falciform ligament. And then hanging over the caudate lobe is going to be the inferior vena cava. Okay? So 4 lobes, right, left, caudate, quadrant. So the liver produces bile. Once bile is produced, the bile can go into 2 different directions. It can go straight into the duodenum, okay, where bile is delivered, so that it can help emulsify the fats, or it can make its way into the gallbladder. Again, the gallbladder is what stores bile, right? So from the liver, we have this series of ducts, series of pathways. You have a right hepatic duct that is analogous or in relation to what?
Right
What
lobe.
part of the lobe? The right lobe. And then you have the left hepatic duct that's related to the left lobe. Okay? So you have the right hepatic duct, you have the left hepatic duct. They join to form the common hepatic duct. From there, it can go straight on into the common bile and deliver its bile into the duodenum, or make its way into the cystic duct, through the cystic duct, and store the bile in the gallbladder. Okay, any questions here? Now there's another vessel here, another duct that comes from the pancreas, and that particular duct is known as the pancreatic duct or the duct of Wersham. Wersham. Gallbladder. 3 major parts. The most distal part of the gallbladder, the most distal part is the fundus. It kind of looks like a pear. It's kind of bulbulous. You have the fundus. The majority of the gallbladder is called the body. It starts to taper down to the neck, and then you have the duct itself. The duct, within the duct, is you're going to have the spiral valves. It's a little kind of spirally. Okay. Okay, it's spirally. The whole purpose of the spiral valve is that it prevents dilation and also contraction. I shouldn't say prevent. It controls expansion and contraction of the duct. So when it contracts, it does 2 things. It can keep the bile in storage up here so nothing comes out, or it contracts to help squeeze the bile out of the duct. Okay, so the contraction. The gallbladder is 7 to 10 centimeters and stores about 30 to 40 milliliters of bile. So the function of the gallbladder is to store bile. Its other function is to keep the bile concentrated. Now what happens here is there is water inside the gallbladder, and the gallbladder regulates the concentration of the bile. Now, through the process of hydrolysis, if too much water is removed from the gallbladder, this is how stones are formed. Because the bile becomes too concentrated and they can turn into stones. So gallstones are known as choleliths. Choleliths. There is this chemical that your body secretes. It's known as cholecystokinin. The duodenum secretes it. Does anybody know how to eliminate that so it doesn't keep popping up on the screen every time I get an email?
Settings notifications.
Setting on notifications, you can show that to me later? Okay. All right. So during the digestion process, the small intestine will sense fat, and in doing so, the duodenum is going to release these chemicals known as cholecystokinin, short CCK. And what CCK does is that it stimulates the gallbladder to contract. So when the gallbladder starts to contract, then bile is released by way of the cystic duct and into the duodenum. Okay, so CCK causes contraction of the gallbladder. Now, what CCK also does, it's not on the slide, but it also activates the pancreas. So when the CCK kicks in, it activates the gallbladder and activates what? The pancreas. Again, because the pancreas is responsible for also regulating, we're not regulating fat, but it's regulating what? Okay, your blood sugar. Okay, so it does those two things. Okay, any questions so far? All right, so the distal common bile duct. So here's your common bile duct. Okay, now as it makes its way down to the duodenum, it's going to meet with the pancreatic duct. This is the duct coming from the pancreas. Now, in 40% of the population, it's in your book, 40% of the population, these ducts are separate. So you have a separate hepatic duct and you have a separate pancreatic duct. They're usually separate. In a majority of the population, 60%, these two ducts will join. So at the point of junction where they join is known as the hepatopancreatic ampulla, or Darth Vader.
We put that on our chest.
Ampulla of Vader. Okay, so where the hepatic and the pancreatic duct meet is known as the ampulla of Vader. Now at this ampulla of Vader, you can see that it starts to get narrow. That is the most common place where gallstones will get stuck. Okay, common place for gallstones to get stuck.
On the radar or on the odd unit?
At the Vader.
Not the beaver.
At the Vader. Okay. Ah! Help me, okay. All right, and right at the distal part of the ampulla, now you have the sphincter that controls the opening. Okay, so opening of that area now. And so this sphincter is known as the sphincter of Oddi.
That's not Star Wars movie. Can we do
No,
that?
that's
Obi-Wan
Garfield.
Kenobi.
Obi-Wan Kenobi.
That's pretty good.
Obi-Wan Kenobi. Can you guys make a shirt of that? The ampulla of Vader with Obi-Wan Kenobi? Can we,
Wham,
is there
bam.
some kind of licensing violation?
Long like your
Can we do
profit.
that?
Yeah.
That's pretty smart.
That's okay.
Extra credit. You just pulled the Bahar.
Doing it every time.
Hey, at least you have something named after you, Bahar.
Once in a while.
At least it's not
All right. So that's the sphincter of Oddi. Now, there's a muscle over there around the sphincter of Oddi that becomes very hard, can be very rigid, and if it's hard and rigid enough, it can cause part of the internal mucosa to stick out. And if it sticks out like that, this is known as the region of the duodenal papilla. It's a protrusion of the inner lining of the duodenum in that particular area, right here, where the ampulla is located. And if it sticks out, that's known as the papilla of Vader. So it's just a little protrusion of the inner lining of the duodenum. Okie dokes? All right. I don't know why this got cut off. What happened here? Give me just 1 second, guys. What's going on here? Why is this cut off?
That's the exam
Huh?
question.
Question what?
That's the exam question.
This is an exam question?
Just make sure that everyone knows.
Yeah. I don't know why I got cut off. There you go. Okay. Everybody got that? Found in 60% of the population. Okay. So again, those two ducts are generally separate, but majority they join together. Okay. Anatomical relationship of the liver and the gallbladder. The gallbladder is going to be anterior. The ducts are going to be more posterior. So you have your cystic duct and your common hepatic duct that is more posterior, while the gallbladder is anterior. Now this is significant when we're taking x-rays of the gallbladder. It's not going to be as common as it was years ago, but do we still do studies of the gallbladder? The answer is yes. Where are most of the procedures done now, if not in x-ray?
CT.
CT and
MR.
ultrasound. CT and ultrasound. Okay, so those are the two modalities that evaluate the gallbladder now. But again, positioning is very significant, because if we wanted to focus on the gallbladder when it's contrast filled, what is the best position to do this, in a PA or an AP? Okay, somebody said PA. Why PA?
Because it's closer to
Okay, PA. So does that mean on your back or on your belly?
on your belly.
On your belly. Do you guys remember, this was 1 semester ago, you guys couldn't tell me what a PA was. You guys remember that?
Mm-hmm.
You guys were looking at me like, what are you? Yeah, exactly. Like, me shut up? No, but I mean, that's true, right? Because it's, you know, a semester ago, you guys had no idea of all these terminologies that we were talking about. Now you're using it as part of your normal language. Isn't that weird?
Yeah.
Do we have to separate you guys?
Oh,
Yes.
Yeah. All right. Now, if we want to evaluate drainage of the gallbladder, no. Do we want PA or AP? If you want to evaluate the drainage. APs, because if they're laying on your back, then the bile is going to want to go towards gravity, right? So then we would do AP. Okay, questions? All right, so now we have here RPO is a more specific view that we do for the gallbladder. When you are getting called to the operating room in OR for a cholecystectomy, and they're asking you to do a cholangiogram, when you walk into the operating room, the patient will be tilted in an RPO position. The patient's not going to be in an RPO, but the table will be rotated in RPO position. The purpose of the RPO projection, or position, moves the gallbladder from the center or the midline of the patient away from the spinal column. Okay, so we're trying to remove any type of superimposition. So you'll walk into the OR room, the table will already be tilted for you. All you gotta do is just slip your image receptor underneath. Okay, and make sure it stays underneath the table and doesn't slide off because of the table tilt. You guys ready for OR?
Yes.
You guys scared about doing OR? That was my home. Did I tell you guys that? I saw so many BEs, well actually did so many BEs, so many upper GIs, that I volunteered myself to be in the OR. I was the OR tech. I did too many fluoro studies. Now, back in the day, there needn't be a technologist to watch you, because what did they say now, when you're doing a portable, a tech has to be with you, right? That was before there was no supervision. I was doing OR procedures by myself. And I got to be really good pals with the, tell me if I've already repeated myself. I had a friend in there, he became my friend, he was Dr. Mitsutani. He was an anesthesiologist. And we were the same age at that time. And we got along, and every time we went to OR, we just hang out and we just talk. Okay, waiting for them to call me to do an x-ray. So come to find out that he only became a doctor because his parents made him.
Oh,
You remember that story? We made him be a doctor. And so his love was being an auto mechanic. An auto mechanic because he loved to trick out the cars. So I had left for a while to pursue other career paths, and then I came back to Anaheim Memorial afterwards, and I found out that Dr. Mitsutani went on to pursue his dream of being a mechanic. So I want to be a doctor. Yeah. It wasn't about the money, it was about what he wanted to do. But he was a very good doctor. The guy was smart, but it's not what he wanted to do. Okay, body habitus, does that play an importance in the location of the gallbladder?
Yes.
It does, right? Okay, because we have 3 pictures here that shows you the location of the gallbladder in each habitus. So when you're hyperstenic, you're wider, you're broader, everything gets pushed up and to the side. Okay? So then your gallbladder is going to be a little bit more on the upper right quadrant and more lateral. If you're sphenic, this is the average size. Okay? Now it's making its way to the lower upper part of the quadrant, making its way more medial or centrally. And aesthetic, right down the middle and much lower. Now, why is this important? Why do we need to know this?
Or area of interest.
Okay. Know the area of interest, because when you go to the OR, you can't see your patient. They're going to be draped. So if you have an idea of what size the patient is, you'll know exactly where to position your image receptor. Okay? On an average size patient, when you're going underneath the surgical trip and you're trying to place that image receptor underneath the table, underneath the patient, what you will see is you will see their elbow as you're placing the cassette underneath. Yes? Okay, so you lift up the drape, you see their elbow, that's your average size patient. That's where your image receptor is going to be. All right? Someone who's a little bit bigger, I'm going to go about 2 inches above the elbow. Someone who may be aesthetic, now it's going to be about 2 inches below the elbow. Okay? So you can't just stick an image receptor underneath the OR table without knowing the patient's habitus, because if you take a shot without knowing the patient's habitus, you may have cut off the gallbladder and the bile ducts. And then, you know, because with computerized radiography, your images are always going to come out nice and clean, right? Very high radiographic quality, right? So no need for repeats. But can you still have repeats? In this case,
Yeah.
it's positional. And if you miss it, you got to go back and repeat it. And now what do you have to do? Doctor, I missed it. Can I do a repeat? They're not going to be too happy. Okay. All right, so here we have a gallbladder First of all, before we talk about the gallbladder, do we know what position this patient is in?
Is it an RPO?
It's an RPO? Yes? That's actually a very good guess, because that's the only position we talked about, right? It's either APPA or RPO. Okay? How do we know it's an RPO?
Spinal column.
Okay, not only spinal column. Did we talk about the Scotty dogs?
Briefly.
No, not yet.
Okay, look up here. There's the nose.
Oh, yeah.
There's the ear. There's the body. There's the tail. Here's one foot. Here's another foot. There's the eye.
Yep, I see it.
You guys see it?
Mhm.
Looks like that ghost dog from
donkey.
the
See?
kids cartoon.
Which one in
Oh,
Jack
the
Skellington?
ghost- Yeah.
Zero?
It looks like that dog.
That's zero. Yeah, that's zero. All right. The nose points to the direction of obliquity, so it's pointing towards the right. So this is your RPO. RPO. Okay. What we're looking at here are the pedicles, the inferior and superior articulating facets of the lumbar spine, and we're going to talk about that towards the end of the course. But I'm introducing it to you now. Okay. But those are all parts of the lumbar vertebrae. Okay. So we said patient was RPO. The whole purpose of doing an RPO gallbladder does what?
Pulls the spine away from the gallbladder.
Okay, so it separates the gallbladder from the spine. All right. What's D?
The fundus,
Fundus, C.
body,
Body, B.
neck,
Neck, and what's A?
cystic duct,
Spiral valve.
Okay, spiral valve in the
cystic duct.
cystic duct. Okay. All right. So this is what you guys are going to get called in for in the OR. It's an operative cholangiogram. All right, so we have the liver. You see the liver shadow here. You have the right and left hepatic ducts. The right and hepatic ducts join to form what?
Common hepatic duct.
Okay, the common bile duct. It's got two ways to go. It can either go to the
Gallbladder.
gallbladder or to the duodenum, okay? So what happened here is that this patient had their gallbladder removed. It's no longer there. It's gone. You see this little nub? Here's that little nub right there. So that is the nub of what?
Cystic
The
duct.
cystic duct. So what's happening here is when they remove the gallbladder, okay, they want to make sure with the injection of contrast, iodine to be exact, they want to make sure that they didn't cut anything else. And they want to make sure that the patency from the liver to the duodenum is still wide open, that passageway has not been interrupted. So that's why you're going in there. Doctor shoots contrast, you're going to take a cholangiogram to make sure that patency still exists. Okay? So the gallbladder's gone. There's the nub. All right? So contrast continues to flow through the papilla, and then what we're seeing here is the most proximal part of the duodenum. Free of flow, no interruption. What is it that we're looking at here? What is this thing? What is this?
That's what I was wondering myself.
Okay, right? Is it a vessel? Is it part of a vessel?
Is it the inferior vena cava?
Look at the line.
Okay. T-tube. It's a T-tube catheter. Okay?
Oh.
So it's a polyurethane catheter that's been inserted into the common bile. So this is the tube that's sticking out. Generally what happens is after a patient has had a cholecystectomy, they will leave the tube in there inside the common bile duct and the other end of the tube sticking out of their abdomen. Okay? 3 or 4 days later, they'll come into the radiology department. They'll put them on the table, evaluate the patient under fluoroscopy. Same thing's going to be done now, except it's in radiology, not in the OR. They'll inject contrast through the tube sticking out. They're going to fill up the ducts to make sure that it's patent and nothing is leaking. And if there's proof that everything's good, they're just going to pull the tube out, Put your finger on there for about 10 minutes to make sure nothing's leaking, and they're good to go. Mhm. Does everybody here still have their gallbladder?
Mm-hmm.
Who lost theirs? You lost yours? How old were you? 22? Yeah. Did they say why? A lot of stones?
My gallbladder was just packed full of gallstones.
Yeah. See, if you have several gallstones, it can be easy to get rid of that. If you have a lot of gallstones, you got to get rid of your gallbladder. Same thing happened to my sister. My sister was 24. She got hers removed. You eat Filipino food?